Excited to have a bit more of a intimate group today, so feel free to come on forward if you're feeling a little far back there. I think we're double, if not triple booked, if I heard correctly, but we're excited that you're all here and able to join us for our second to last, our penultimate lecture for the 2020 Alan M. Boyden Memorial Lectureship Series. For those of you who don't know me, my name is Kevin Dirksen. I serve in the role of Senior Ethicist and Director of Ethics Education at the Providence Center for Healthcare Ethics. And this year we're excited to celebrate 20 years of service to Providence in healthcare ethics. So thanks to those of you who we partner with and who support our work. Just a word of announcement. We're going to go until the end of the hour, and Dr. McGowan will hopefully leave a few minutes of questions toward the end of her presentation, which aims to be a little bit different than some of our ethics education sessions. This is a real journey into the health humanities. It's an opportunity to dive into the history of medicine in ways that we typically don't host sessions in that way, and so we're really excited to see what you all think about this. And as always, please share with us feedback in our evaluations for future programming. For those of you who don't know Dr. Boyden, the namesake of this lectureship series, Dr. Boyden was a surgeon at Providence St. Vincent Medical Center for 48 years. He practiced, and a well-recognized figure not only at St. Vincent but in the greater Portland community. Dr. Boyden was one of those docs that really was able to demonstrate wholeness in the physician-patient relationship and urged those with whom he practiced those same skills. And so we're excited to be able to continue that legacy with this lectureship series. In the spirit of Providence and beginning our meetings with a reflection, I'd like to offer an excerpt from The Things They Carried, a collection of short stories by Tim O'Brien as based upon his experience as a soldier in the Vietnam War. They carried all the emotional baggage of men who might die. Grief, terror, love, longing. These were intangibles, but the intangibles had their own mass and specific gravity. They had tangible weight. They carried shameful memories. They carried the common secret of cowardice barely restrained, the instinct to run or freeze or hide. And in many respects, this was the heaviest burden of all, for it could never be put down. It required perfect balance and perfect posture. They carried their reputations. By and large, they carried these things inside, maintaining the masks of composure. And now it's my privilege to introduce our 2020 Boyden Lectureship speaker, Dr. Torree McGowan. Dr. McGowan is an emergency room physician and board certified in emergency medicine and a fellow of the American College of Emergency Room Physicians. She practices in Bend in Central Oregon with St. Charles Medical Group and comes to us today with a wealth of experience in things like disaster medicine and casualty response and thinking about things that seem very far from our lunch here today. But we're really excited that she's here and speaking to us about one of her interests in narrative medicine and looking into practices that connect to how we might better understand our clinical practices in medicine a bit better today. She's been published in the likes of the New England Journal of Medicine and a Health Humanities Journal and other publications, and we're really excited to be able to spend time with her today and to learn what she has to offer us. So thank you, Dr. McGowan, and please welcome our speaker.
Thank you. All right, this time I'm going to remember to switch it over. I forgot this morning. Before I get going, these are my required disclosures. Please know that these are my opinions and do not represent the opinions of the United States Air Force, the Department of Defense, or anyone else. I also have no relevant financial disclosures for this particular story. It's also lunchtime, and I do use pictures from real mass casualty incidents, so I apologize. The timing's not good. I would also like to give a special thank you to Staff Sergeant Stacy Pearsall. She was a combat photographer with the United States Air Force. She is now medically retired from her injuries that she sustained while she was serving with the Air Force. She graciously allowed me to use many of her images for this lecture, and I appreciate that. You can see more of her incredible work at veteransportraitproject.com. If you attended my lecture this morning, you know that I'm a storyteller, and I love hearing patient stories, but medicine itself has a story as well. And the things that we do for patients have a story behind them. The history of medicine and war is intimately intertwined because there is no human endeavor that creates the sheer number of wounded and ill patients like the organized violence of war. And with every war, there is a doctor waiting to treat those patients. This is the story of the research and the history that goes behind the first hour of the resuscitation of one of my patients, and I hope you enjoy it. I don't remember his name. It's funny because I'm usually really good with names, but not here, not in this place. There are so many patients who come in that are too injured to even tell us their names that we just give them a name. But I won't ever forget their eyes. And I won't ever forget the things that made it so that I could take care of this patient as he came to me. This day started like any other for my soldier. He got up and he brushed his teeth and he put on his uniform and he laced up his boots. He picked up his battle rattle and slung his rifle over his shoulder and he wondered, is today going to be the same as every other day? Walking for hours on patrol in this soaking fear? Waiting for something to happen? Or would today be different? It became incredibly evident in an instant that today was going to be very different. And of a sudden, it's noise and pain and dust and the ringing in the ears. And he feels someone pulling on his leg and he doesn't understand why. The first intervention that my patient will feel is a combat medic placing a tourniquet on his legs. The history of tourniquets, this is how I will step through this. It's on a timeline, and we will walk through that. And those timelines are actually available online that you can walk through and see these images as well. The first description of tourniquets in the medical literature was found in Hindu texts in 500 BC. They described the use of tourniquets for snakebite. Hippocrates wrote about tourniquets in 400 BC. He described the complication from bandaging an extremity too tightly, leading to distal limb gangrene. There was no discussion of hemorrhage control, but they correctly identified that you could do something to the blood flow if you bandaged that limb too tight. The first military use of tourniquets was in one of Alexander the Great's campaigns. So he had a battle called the Battle of Hydaspes in the Indus River Valley. This was as far east as the Alexander the Great's campaigns had taken him. And during that battle, his soldiers were bitten by unfamiliar snakes and began to fall ill. So what does any good military commander do? He captures surgeons from the other side and said, fix my soldiers. And the way that they treated them was with tourniquets to isolate the snake bite. This was the first military use of tourniquets in the medical literature. Galen wrote about a phenomenon in around the 120s BC that he described as the bag of waters analogy. So he understood that if we took a constricting band around an extremity, and if you put it on fairly loosely, you would increase the bleeding. But if you tightened it down even more, the bleeding would stop. Now remember back then, they didn't understand how blood circulated. They didn't understand arteries and veins, and so they had no understanding of why that would happen. Now we know that as venous constriction and then finally arterial occlusion. But the only way he was able to describe that was a bag of waters analogy. And so what he thought of was this big bag that was full of water. And if you started to squeeze it a little bit, you would increase the water coming out because of the pressure. But if you squeezed it all the way down, the water flow would stop because you'd run out. That was the only thing that he could describe how this might happen with what they saw. There was about a millennia where the research stopped until this gentleman, Hans von Gersdorf, who was a Prussian surgeon, described for the first time the use of a tourniquet for hemorrhage control. This was after a battle, and they used it prior to amputation of this patient's limb. This is actually an illustration from his book, and as you can see, this guy had a really bad day on the battlefield. Wilhelm Fabry in 1593, came up with a modification of the tourniquet that we still use today. He had a bandage that he put a stick through and created a twisting mechanism. He invented the very first type of what we now call a Spanish windlass type of a tourniquet, and this is a tourniquet design that we use now today in our common military supply. He is regarded as the father of German surgery, so this is a name that you may notice. William Harvey in 1628 helped us make a giant leap forward in our understanding of how tourniquets might work. He was the first person who correctly described how blood circulates in the body. He was not allowed to do autopsies on people, and so this was actually published in his book On the Movement of the Heart and Blood in Animals. So this was all animal data, but he was the first person to correctly identify the idea of the pulmonary circulation and the systemic circulation, and this is his diagram from his book. This is where we start to understand how a tourniquet might actually work instead of that bag of waters analogy. Etienne Jean Morel wrote about the first use of tourniquets in battle to control hemorrhage at the Battle of Flanders. This was one of Louis XIV's surgeons. Jean Petit-Louis, another Frenchman, created a significant change in the history of tourniquets with his invention of the screw-type tourniquet. So this was a tourniquet that you would place around the extremity, and then you'd place that screw mechanism over the pulse, and then twist it down to try to occlude the pulse. It didn't work particularly well, but Petit's tourniquet did have a very important impact on the history of this story. Because of that twisting motion, that's actually where the name tourniquet comes from. It comes from the French word to turn, or tournier, and that is why we call them tourniquets, thanks to Jean-Louis. The American Civil War saw continued use of the Petit-type tourniquet. This is an illustration from one of the surgical handbooks at the time. Published in 1853, it shows how to correctly apply Petit-type tourniquets on your brachial, your femoral, and your popliteal arteries. This is an actual Civil War tourniquet that's displayed at the National Museum of Health and Medicine in Washington, D.C. If you ever go out there, it's a fascinating museum to go visit. Union physician Samuel Gross actually had put out a notice to all of his soldiers that every man should put in his pocket a stick of wood, 6 inches long, a handkerchief or a piece of roller, and a thick compress, and be advised how, when, and where to apply it. Back in the Civil War, we said, bring your own tourniquet, because we don't bring them. But they understood that they were important. 50 years later, at the start of World War I, this was the tourniquet that was used for our American soldiers. It was a 1.5-inch piece of cotton webbing, 42 inches long. It had a spring-type buckle, but no method to turn it or to tighten it down any other way other than just basically putting on a tight belt. This was ineffective at stopping femoral artery hemorrhage, and this is where the idea that tourniquets were not effective and were dangerous starts to come from, because this was an ineffective type of tourniquet. This idea got further traction in the Spanish Civil War in the 1930s. A New Zealander named Douglas Jolly was deployed with the Spanish Republican Army, and he wrote, based on his experiences at the front, in an article that said, "More limbs and lives are lost at the front from improper use of the tourniquet than were saved by its proper use." Okay, I actually could probably agree with that. If you don't use it right, you could probably hurt somebody, okay? The problem came when this gentleman, Sir Reginald Watson Jones, read what Jolly had written and then changed it a little bit. So this gentleman was on the War Wounds Committee of the Medical Research Council in England. He actually was not a combat physician, but he read what Jolly wrote and changed that up a little bit. And what he said was more lives have been lost than were ever saved by the tourniquet. Not quite the same, and it was very powerful because this gentleman taught at one of their medical schools and taught an entire generation of surgeons that tourniquets were dangerous. That idea persisted up through World War II and into the Korean War. Korean War saw continued use of those same types of tourniquets that we saw in World War I, but there was one important event that happened in the Korean War. There was a paper published in the Annals of Surgery by Arts and his colleagues entitled Clinical Experiences in the Early Management of the Most Severely Injured Battle Casualties. This is the first time in medical literature that they linked hemorrhage control to improve survival. Seems really basic to us now, right? If you stop people from bleeding, they won't bleed to death. This was the first time that that was actually proven in the medical literature, thanks to Arts. Vietnam saw continued use of that same type of ineffective tourniquet. 7% of all battlefield deaths in Vietnam were from isolated extremity hemorrhage. They estimate that if they had had a functional tourniquet in Vietnam, that 2,600 more soldiers could have come home and survived their injuries. The Battle of Mogadishu in 1993 was another opportunity to learn a little bit more about tourniquets. So most of us know this as the Black Hawk Down incident. This was Mogadishu, Somalia. There was a ranger regiment that was involved in a conflict with the local warlords, and during that battle, there was a ranger regiment, and one of the rangers was shot through the tibia. His medic that was taking care of him was a gentleman named Sergeant First Class Bob Mabry. They were pinned down throughout the night and they couldn't make it back to base. And so Mabry put a tourniquet on this guy's leg to keep him from bleeding to death. But he had heard all of these things about tourniquets being really dangerous and making your leg fall off. So throughout the night, he would loosen that tourniquet to restore blood flow, and then he'd tighten it back up before he bled to death. Now, once they finally made it back to the base that next day, Dr. Holcomb, John Holcomb, who was the surgeon deployed with that ranger regiment, offered what I can only imagine was positive and uplifting feedback, in the way that Army people generally offer their feedback, to Sergeant Mabry, saying, hey, the way that you kept taking that tourniquet down, you probably made him bleed more because and you probably caused some reperfusion injury. This ignited a passion for hemorrhage control in Sergeant Mabry, who went on to medical school and became Dr. Mabry. And John Mabry is now, he actually just retired from the military and was one of the foremost researchers in pre-hospital care and tourniquet development in the United States military and in the US. Despite learning those lessons in Somalia, or starting to learn them, at the start of Operation Enduring Freedom, or the Afghanistan War, the first fatality was on January 4th, 2002. His name was Sergeant First Class Nathan Chapman. He had an isolated gunshot wound to his femoral artery, and he died en route to surgical care without a tourniquet on. It became very quickly evident during the Afghanistan War that we needed to change how things were being done. And so in 2002, Colonel Holcomb, who used to be Dr. Holcomb back in Somalia, was the commander of the Institute for Surgical Research in San Antonio, Texas. And that's the Army's research branch. And he gathered all of these special operations medics who had been deployed together, and he said, what do you guys need to save lives? And one of the things that they identified, or one of the first things they identified, was a functional tourniquet that could be applied with one hand by the person who was injured. The request for proposal went out, and this was the tourniquet that they first identified as meeting the standards. This is the Combat Application Tourniquet, or CAT tourniquet. In 2003, Surgeon General of the Army, Kevin Kiley, put out the recommendation that all soldiers deploying carry this type of tourniquet on their persons. Many of you might be aware that military appropriations don't work that way, and just because you say it doesn't mean that say that you need it doesn't mean it's paid for. It took until 2005 when this article ran on the front page of the Baltimore Sun that says, modern combat lacking in old medical supply. Deaths because of blood loss from wounded extremities could be reduced if all soldiers carried $20 tourniquets. This ignited a public outcry and a congressional inquiry and actually resulted in the money being funded so that these tourniquets could be supplied to our soldiers downrange. And that brings us to current times. The most recent publication about tourniquet use in the military was in Annals of Surgery in 2009, written by Craw and his group. And the current research indicates that if you have an isolated extremity hemorrhage, isolated extremity wound, and you have a tourniquet placed in the pre-hospital setting, your survival is 89%. If it's not placed until you reach the hospital, 78%. If you have your tourniquet placed prior to the onset of shock, your survival is 96%. After the onset of shock, 4%. If you have an isolated extremity hemorrhage and you have a tourniquet placed at any point in your care, your survival is 87%. If you do not ever have a tourniquet placed, your survival is 0%. And Crau's conclusions from that are the right tourniquet used in the right, or placed at the right time in the right way for the right casualties saves lives. And that's probably a little better lesson than what Reginald Watson-Jones taught us. And now the tourniquet's in place, and it's time to move. How do we get where we need to go? The military does casualty evacuation like no one else in the world. We move patients all across the globe and continue that care throughout the spectrum of the patient movement, and this is a story of how we develop those skills. The story starts in around 900 AD with the first descriptions of patient transport by the Anglo-Saxons using oxen cart. The Normans in France were doing similar work around that same time with horse-drawn wagons. I'd love to tell you that this was patients being moved for compassionate medical care. Unfortunately, these were the mentally ill and lepers being taken out into the countryside and dropped off. It's the first time we move patients, but maybe not for the reason we'd like it to be. About a millennia happened where not much occurred until a gentleman named Dominique Jean Leray at the Battle of Metz in 1792 created what are called his ambulances volantes. So this was one of Napoleon's surgeons in his Grand Army, and he'd watched how the artillery moved around the battlefield being drawn by horse-drawn carriages. And he came up with the idea that we may be able to move patients the same way. This is his diagram of his ambulances volantes, and this was the very first description of an ambulance and an organized EMS system in the world. Those ideas came to the United States about 100 years later, thanks to a gentleman named John Letterman. So in 1861, there was a battle called the Battle of Manassas, and it took over a week to get all of the wounded off the battlefield. Now, the military is no different than a lot of major corporations. When something that spectacularly bad happens, everybody at the top gets fired and you get to start again, right? So one of the people that got hired to replace one of the people that had been removed was a gentleman named John Letterman. He was a major at the time. And he had some really radical ideas on how he wanted to do medicine for the Army of the Potomac, which was who he was the medical director for. He had radical ideas like, you should be treated based on how bad your injury is, not based on your rank. Ideas like the supply of how we get things to the battlefield. So up until that point, the quartermaster of the Army was in charge of getting everything, all of the supplies, to the field where you needed them. So that was uniforms and bullets and food. And what happened is a lot of times things like bandages and medicines were prioritized very low because they said, well, you don't need them yet, and you might not need them after the battle. It's not like anybody's going to get hurt, right? So a lot of times they just wouldn't have the supply that they needed. And so Letterman took medical supply away from the quartermaster of the Army and set up his own medical logistics chain so that he could guarantee that the stuff that they needed to take care of patients wouldn't get prioritized under food and bullets. He also created purpose-built wagons that you can see here that were his ambulances to go out and gather wounded from the battlefield. So less than a year after the Battle of Manassas, and about 2 months after Letterman took over, there was the Battle of Antietam on September 17th, 1862. Antietam is still, in US military history, the bloodiest day of battle that our country has ever seen. 17,000 wounded soldiers. And every single one of them was removed from the battlefield in less than 24 hours, thanks to Letterman's changes. His influence is still felt very strongly in the military today, and we still use those ideas. He is considered the father of modern Army medicine. The first recorded aeronautical evacuation of a patient was in 1870 during the German siege of Paris during the Franco-Prussian War. 160 patients were evacuated via weather balloon. World War I saw the advent of the motor-driven ambulance. This was a Model T Ford cracker box type of ambulance. It had a wooden frame and a canvas top and a blistering top speed of 45 miles an hour. World War I also saw the beginnings of the aviation era. So at that time, aviation was still incredibly dangerous. Planes liked to crash a lot. But some forward-thinking people still saw the opportunity to move patients via aircraft. Dr. Eugene Chassaing was a Frenchman who developed this idea, this prototype of how you might be able to move a patient in a World War II era biplane. He had a lot of critics, and one of his critics was quoted in the newspapers with the scathing remark of, "Are there not enough dead in France without killing more in airplanes?" However, that idea stuck and continued to be developed. This is a picture of a World War I type aircraft that has been renovated into an ambulance. You can see the patient there loaded backwards right behind the pilot. This was in 1919 and taken at Ellington Field in Houston, Texas. By World War II, aviation had gotten considerably safer, and at that point, 625,000 US casualties were moved by aircraft. 25% of all of our wounded moved home on aircraft. World War II also saw the development of flying nurse orderlies. We all know these now as our flight medics and flight nurses. They were responsible for helping manage the physiology changes that happen to a patient during flight. They were also really good at the equipment that was required. So these nurses could change an airplane from cargo configuration to being ready to patient transport in 8 minutes. And they can do it just about that fast even now. The Korean War saw the rise of rotary wing evacuation for patients. So the 3rd Air Rescue Squadron from the United States Air Force was sent to Korea to rescue downed pilots. But we had pretty good air superiority, so not many of those planes crashed during that time, so they sat around not doing much. And they started getting requests to go pick up men from the battlefield and bring them back to the hospital. This happened so often that in January 1st, 1951, they officially designated the 3rd Air Rescue Squadron as the Air Ambulance Detachment and stood it up to fly aeronautical evacuation missions. Their aircraft was the Bell H-13 helicopter. It's a light observational helicopter that was retrofitted with patient pods on the skid so they could carry 2 patients at a time. It had a maximum flying distance of 2 hours. That was often not long enough to get to a battlefield and back, so they carried their own gas in a can with them. It didn't have a strong enough battery to turn on without an auxiliary battery, so what they would do is they would fly to where the patient was, they would land, they would leave the engines on and the rotors spinning, they would refuel with their own gas cans, and then put the patient on and fly home. They also didn't have any lights in the cockpit, so there were no lights on this entire aircraft. And so on the rare opportunities that they had to fly a night mission, the pilot would fly with a flashlight clutched between his knees so he could see the instruments. These guys were incredibly tough. These Korean War pilots were also the first ones to start thinking about, could we resuscitate somebody in flight? So Lieutenant Colonel James Brown of the 863rd Mobile Army Surgical Hospital, or MASH Hospital, came up with the idea of giving transfusions during flight. So patients would be in the patient pod, and the pilot would have a bottle of plasma right there next to him, and then the tubing would snake out into the patient pod, and the pilot would be responsible for regulating the flow of blood using a little rubber pneumatic tube, or rubber pneumatic bulb, and flying the aircraft and not crashing. This was the first idea, though, that we might actually be able to do something other than take someone from place to place. Vietnam saw continued use of rotary wing aircraft. Over 900,000 patients were moved via aircraft during the over 10 years of conflict. There was a really interesting subplot of the story during Vietnam. So in 1963, the Army's 57th Helicopter Ambulance Detachment was deployed to Vietnam. And their commander was a gentleman named Major Lloyd Spencer. And he, up until that point, medical evacuation would use whatever radio frequency was available and whatever call sign. They would usually say, this is Army 57. Everybody knows what call sign is, right? Maverick, Goose, that's what they call you on the radio. So their call sign was just Army and their tail number. And Spencer said, you know what, I don't like this kind of slap hazard thing. I want my own call sign and I want my own frequency. And so he went down to Saigon and went to the Naval Support Activity because those were the people that regulated that for the country. And they gave him the Signal Operations Instruction book that listed all of the unused call signs for the country. And so he starts paging through it, and he starts at the A's, and he's looking, and he sees aggressor and assault and bandit, and he thought, you know, none of that sounds right for a helicopter, for an ambulance service. Sounds more like an attack, you know, like the fighter squadron should be having that. And so he finally gets to the D's. And he thinks about when the helicopter lands, how much dust is blown up off the ground by the rotor wash, and it would rip the tents out of their pegs, and paperwork would be flying everywhere. And so he chose dust off as the call sign for the 57th Helicopter Ambulance Detachment. And that is a call sign that endures today. If you ask any Army person, or if you call for dust off, they will know to send you medevac. After Vietnam, we entered a time of somewhat relative peace during the Cold War. In 1983, the Marine barracks in Beirut were attacked by a terrorist bomb. Those Marines were then evacuated through Germany on their way back to the United States. And there was a surgeon there named P.K. Carleton, he was an Air Force surgeon, who watched that evacuation happen and realized that we actually don't have a very good system for moving patients back to the United States. And he started thinking about how do we make this system work better? He identified the importance of modular teams so that you could hand off and switch out so that we were able to not burn out our people. He talked about the importance of team training so that everybody knew what everyone else on that team was doing. He talked about the importance of joint operations. So still in the military, if you are Army and you're injured, you will fly on both Army and Air Force Army and Air Force aircraft during that evacuation chain. Instead of the Army is going to move all the Army people and the Air Force is going to move all the Air Force people, we do what we do best and move everyone through that system. He also talked about the importance of critical care en route and continuing to do that resuscitation, just like Brown did during Korea. And they came up with the idea of the Critical Care Air Transport Team, or CCAT team. In 1992, during the Bosnia conflict, the very first patient was moved with a CCAT team. This was a young gentleman who stood up on the back of a train boxcar and contacted a high voltage wire. So he was electrocuted and then he fell off the top of the boxcar. Multiple fractures, very badly injured patient. They picked him up in Germany and they flew him home with a CCAT team back to San Antonio. Somewhere over Greenland, he became septic and they were able to resuscitate him and continue his care in the air and land him in Texas with better physiology than he left Germany with. This was the first proof that actively resuscitating patients during their evacuation was possible and could result in better patient outcomes. That idea of integrated en route care is alive and well in our US military now. This is a CCAT team taking care of a patient in the back of a C-17 aircraft. We are continuing to push these ideas further forward. This was a patient in 2016 being picked up with, he actually had bad blast lung, and the ECMO team was picking him up in Bagram, Afghanistan, and flew him on portable ECMO from Afghanistan all the way back home. Air refueling en route, so they never touched down from the time they left Afghanistan till the time they touched down in the United States. They are also looking at putting physicians further forward and closer to the point of injury. This is a British team actually called a MERT team, a Medical Emergency Response Team, that puts physicians close to the point of injury and allows that resuscitation to start. There's even studies looking at doing surgery in the back of an aircraft and doing that damage control surgery right at the point of injury. Today, if you are injured in Afghanistan or Iraq, the first person you will meet will be your combat medic. They will then evacuate you usually via ground ambulance to a battalion aid station. Within an hour, you will move to a Role 2 where your damage control surgery will happen. Within about 6 to 12 hours, you will then move to an Air Force theater hospital for further or a combat support hospital, that's the Army equivalent, for further damage control resuscitation. Within about 24 to 72 hours, you will be back in Germany for further surgeries and back into the United States within less than a week. That's much different than what we did during Vietnam and Korea, where we sent the whole hospital there rather than bringing patients to our care here. And we have seen a significant change in what we call our combat mortality rate. So this is a really rough number that looks at if you are injured in battle, how likely are you to die of that injury? World War I, World War II, 30%. So if 1 out of 3 people died if they were injured in battle. Korea, Vietnam, even Persian Gulf, which isn't that long ago, still saw 24, 25%. Operation Enduring Freedom and Operation Iraqi Freedom, that's OIF, OEF down there at the bottom, our combat mortality rate is less than 10%, and a lot of it attributes to how quickly we move patients to definitive care. And so now we wait for my soldier to show up. And it's quiet in the trauma bay until we hear the helicopter rotors. And then we get ready to go to work. He comes in, and now it's finally my turn. I see his tourniquet, and now I start my resuscitation. The story of resuscitation really starts in 1665 with this gentleman, physician Richard Lower, who performed the first blood transfusion on a dog. He wrote about his experience in Philosophical Transactions, which was kind of like the JAMA of the time, or the New England Journal. And if you read his article, he talks about how the emittent dog, or the donor dog, began at last to cry and to convulse and at last to die. Basically, he bled one dog to death to keep the other one alive, which is kind of not how we like to do research now, but apparently they didn't have an IRB back then, so it seemed okay. The next step in this rather dubious history of blood transfusion is this gentleman, Jean-Baptiste Denis, who in 1667 published in that same Philosophical Transactions an article entitled "Touching a Late Cure of an Inveterate Frenzy by the Transfusion of Blood." We don't title things near as cool as they used to, by the way. Inveterate frenzy. If you read the article, though, the basic idea of this experiment was to take a mentally ill patient, and they chose a calf based on its mildness and freshness. And their idea was that they could take blood from the calf and give it to this mentally ill man and cure his mental illness. Now, shockingly, this did not work, but it also didn't kill him, so they continued to do more experimentation. Transfusions were outlawed in France in 1668 when one notable experiment had 2 of 4 patients die. All of these transfusions at this time were from animal to human, so usually goats, sheep, and cows being the donors. It wasn't until 1818, on December 22nd, that James Blundell, who was an English surgeon, performed the first human-to-human transfusion. And this is actually from his article that he published about 10 years later in The Lancet with a sketch of how they did it. This was used to treat a lady with postpartum hemorrhage. First human-to-human blood transfusion. Transfusion experimentation continued for the next 50 to 60 years, again, usually using animals, and they had some really weird pictures like this, because remember, you had to be in close proximity because we couldn't store the blood, so it had to go directly from one to the other. Doesn't seem really very clean to have all those farm animals around. 2 transfusions were performed during the American Civil War. This was extracted from the medical and surgical record. A few remarks on the transfusion of blood with a modification of the apparatus of Aveling. This is the apparatus of Aveling that they used to take blood from one person and put it directly into the next. Transfusion science took a giant leap forward in 1901 thanks to this gentleman, Karl Landsteiner. He correctly identified the 3 blood groups, A, B, and O. He won the Nobel Prize for this in 1930. Ludwig Hectoen took that idea of blood groups in 1907 and postulated maybe there's something about why blood transfusion is so dangerous with these blood groups. And maybe if we matched the blood group, transfusion might be safer. Reuben Ottenberg took this idea a year later and performed the first cross-matched blood transfusion. Roger Lee in 1912 identified the O blood group as the universal donor type. And this is information that we still use today. If you're using uncross-matched blood on a patient, you use type O blood, thanks to Roger Lee in 1912. 1914 saw the development of citrate as an anticoagulant, so we could actually start to store blood. Up until then, we had glass bottles that were coated with paraffin, and it was not safe to store blood for any length of time, and so it had to, again, be from person to person. The ability to store blood allowed Oswald Robertson to develop the very first blood bank in 1917 in France to treat soldiers wounded in battle. Excuse me. He only accepted type O blood donors because they were not able to do matching downrange. The Spanish Civil War saw continued use of blood transfusions. The Barcelona Blood Transfusion Service would take blood from multiple donors and pool it into one big pool, and then would take aliquots and transfuse into other patients. One thing that they did do was kept meticulous records of the donors and the recipients, and so when you're filling out those triplicate blood transfusion forms that we all know and love, you can thank the Barcelona Blood Transfusion Service for the record keeping. In 1939, Landsteiner and his group identified the Rh factor as the major contributor to the remaining blood transfusion reactions that we were seeing, and continued making blood transfusions safer. Edwin Cohen, who was a professor of biochemistry at Harvard, in 1940 developed the technique of cold fractionation, which allows us to break blood into components. So up until then, all we had was whole blood, and now you could fractionate it into packed red blood cells and platelets and plasma. World War II saw most of our blood being sourced through the American Red Cross, and using that fractionation technique allowed us to store blood for much longer. Plasma was the main component that was transfused at that time. 1942 also saw our blood supply being screened for the very first time for an infectious disease, and the first disease that we screened for was syphilis. Component therapy was the standard at the end of World War II because you could store components much longer than you could for fresh whole blood, and that's actually still true today. The Korean War saw continued use of blood transfusion. We relied very heavily on type O blood because it was difficult to cross-match downrange. Everyone asks about the dog tags. There was a landmark study in Korea that saw an 8% error rate in dog tags. So if you look at someone's dog tag, their blood type is a fairly high risk of being wrong. And that's still true today because as a military member, when you go and you get your new dog tags, they'll say, "What's your blood type?" And you go, B. I don't know. And they will very dutifully put it on your dog tags. So we still don't rely on that even today. We are able to cross-match much more quickly, but we use the dog tags for walking blood bank identification, but we do not use it for transfusing into a patient. The Korean War saw 50,000 blood transfusions given, again, still mostly plasma during that time. During that 50,000 transfusions, they only saw 4 major hemolytic transfusion reactions, and all of those were through locally sourced blood. The Armed Services Whole Blood Processing Lab had been stood up by that time and handles all of our blood for the United States Air Force, and had 0 transfusion reactions for our blood that was handled that way. Now in 1993, we started to learn some more information about how to take care of these soldiers that are massively injured. This was again the Black Hawk Down incident, and Rotondo was a surgeon who was stationed there with our special operations group. And he wrote an article called Damage Control, an approach for improved survival in exsanguinating penetrating abdominal hemorrhage. He was the first person to come up with the idea of what we call a damage control surgery. So up until that point, when a surgeon went in to fix something, they were going to do the entire surgery, put everything back together, and make everything perfect in one shot. Now, thanks to Rotondo in 1993, they came up with the idea of go in, pack it off, tie it off, make it stop bleeding, and know that you're going to go back in there a few more times and do more surgeries to fix things permanently. And this is an idea that we still use today. Mogadishu also saw the first use of the fresh whole blood and walking blood bank, so we did not expect to meet near the opposition that we did in Mogadishu, and so they did not pre-position much blood forward, and so after this huge battle, we couldn't get blood there fast enough, and so they used other soldiers in the unit who were not wounded to supply the fresh blood, and they did a fresh whole blood transfusion into the soldiers, and that is something that we still routinely use today in the military when we are running low on supplies. Now, in the civilian world, there was an interesting little side note that started to happen. Factor VII started to make its appearance in trauma care. So Factor VII is a treatment for hemophiliacs and helps their blood clot better. We started using it in trauma patients, and the surgeons loved this. They said, I can watch the bleeding stop in front of me. And so this very quickly got adopted into the trauma lexicon, and we used it in soldiers. But we started to see something strange happen with our patients that we saw downrange. These patients seemed like they were bleeding a lot. And McLeod and his group published in the Journal of Trauma an article called Acute Traumatic Coagulopathy. This was the first time that we started to realize that something about our trauma patients was making them bleed more than we expected them to and not be able to form blood clots. He followed that up in 2004 with an article called The Predictors of Mortality in Trauma Patients. This was the first description of what we call the lethal triad of coagulopathy, acidosis, and hypothermia. Patients that come in with any of those have a 75% mortality, and starting to be much more aware of that in trauma care, and how do we start to reverse those 3 deadly events in trauma care. Now, in the mid-2000s, we started to see some interesting things happen with our patients that had been treated with this Factor VII medicine that I mentioned before. What we noticed was these were young men, 20-year-olds, that were coming back from Iraq and Afghanistan, and they had gotten this medicine during their care, and they were having strokes. They were having heart attacks and big blood clots in their lungs, which was not what we expect to see in 20-year-olds. And they started to look at who was getting this and noticed a much higher rate. And we started to be concerned that this medication was causing further problems downrange, or downstream. The early studies looked really good for people surviving their injury, but then would die of clotting complications later on. And so because of that work that we saw in our soldiers and this increased frequency, they stopped using that medicine. It's still in our clinical practice guidelines as an option, but it's very rarely used in trauma anymore because of the military experience and what we saw with our soldiers. Blood transfusion research continued through the next 10 years of the conflicts, and lots of papers started to come out, again, looking at that idea of something about these patients are making them bleed and not form blood clots correctly. The CRASH-2 trial happened in 2010. This was a civilian study that led us to add tranexamic acid into our care of our trauma patients. There is a close interplay between the civilians and the military that you're seeing here, that we'll learn a little bit and it goes out to the civilian world, or the civilians will come into the military. This is a medicine that did not seem to have that clot problem that we saw with a Factor VII, but still decreased bleeding. And this has very quickly been accepted both into the civilian and military trauma care. In 2013, we saw the PROMPT trial, which looked at patients that were receiving what we call a massive transfusion, so more than 3 units of blood during the first 24 hours of their resuscitation. And what they saw was patients who got plasma or platelets with those packed red blood cells tended to die less often. The study was followed up with the PROPER trial in 2015 that really defined this idea much more. And what they finally came up with was the idea that if the correct ratio of giving blood products to patients was a matched ratio of packed red blood cells, plasma, and platelets, which looks an awful lot like whole blood, like what we used to do in World War I. We do, however, now we still do it in components because it's easier to store, thanks to Edwin Cohen. And that brings us up to current times. He's now with me. His TXA has been given and his massive transfusion has started. He's wrapped in a crinkly silver space blanket, and you can hear it rustle as he moves. His vitals have stabilized, but he's far from home. And he'll leave me today, and he'll go off to the operating room for the first of many surgeries. Today is damage control. But what will follow is the end result of all wars, of fracture management and infection control, traumatic brain injury research, prosthetic devices, PTSD, rehabilitation, all beyond the time that I have to share with you here today. Please know that these stories, I picked very small pieces of them because of the time, but the history is so incredibly rich of all of the things that we have learned. We are understanding how important capturing that knowledge is, thanks to the military's, it used to be called the Joint Theater Trauma Registry. It's now the Department of Defense Trauma Registry. It was established in 2006. These are old numbers that I have up here. It is a data repository that holds over 1 million patients worth of information of trauma patients, both battle and non-battle injuries. And we gather that information. It's also broken up into sub-registries, so if you have a particular interest in acoustic trauma or traumatic brain injury, we look at those very specifically in our research protocols. All of this information is gathered from our charts, so every single patient that we see that's a trauma patient will have this chart created for them. This is the physician form, and then the nurses have a very similar form. Every piece of information on this chart is then abstracted by research nurses and placed into this database so that it can then be queried to use to answer research questions. This is 1 year's worth of publications that are based on the Joint Theater Trauma Registry database. If you are interested, this is something that's available to civilian researchers as well. You have to have a military co-researcher, but if you contact the Institute for Surgical Research, they will match you up with somebody. And this is data that is available for the betterment of all patients, not just military. And finally, he's gone off to the operating room, and it's quiet again. And we start to pick up the pieces, both of this one man and of all patients at war. And we restock and we start to think about the lessons learned, and we get ready for the next patient and the next war. And we all hope that we get to go home on our own 2 feet, or at least in the hands of our friends. And we are continuing to learn, and this story is continuing to be written by my colleagues right now who are deployed. And these lessons will come back to the patients that you see today. And I hope that a little bit of the history of how that first hour came about was as enjoyable to you as it is to me to tell. And I'm happy to take any questions.
Well, we've got a couple of minutes. Anyone have a question to close out our hour? Pensive group after lunch.
I realize the timing of the pictures might not have been perfect for the lunch.
Yeah,
but,
we can blame,
yeah,
blame that on the episode.
Can you share your email? I don't think we've ever seen it.
It should be in your handout, but I think I skipped through it too quickly was my biggest problem. Should be right up there, second line from the bottom.
Probably the easiest question you've got over here.
Exactly, man. They've been just crushing me with hard questions, so. Yes, ma'am.
Group of chaplains here, and I was wondering, how do the military medical people get help for themselves after the things they see and do?
That is an excellent question, and one that we continue to struggle with. And medical people is a kind of an expansive term in the military because we have dedicated physicians and nurses that take care of them, and we also have our combat medics who are our frontline medics that are embedded with each unit, and they aren't part of the medicine establishment. For a very long time, it was assumed that doctors and nurses going over there wouldn't have any problems and you wouldn't need any extra support. As this conflict has continued to evolve, we are understanding that that is very much not true, and that the people who come back, who care for those and come back, have rates of post-traumatic stress disorder about on par with the soldiers that were in combat. I would love to say that there's great mechanisms to deal with that, but the military is spending a lot of time and effort in working in that, and the VA, of course, is incredibly helpful in that. One of the biggest problems to accessing that is people asking for help. One of the things that this is kind of a personal passion of mine, I gave a lecture several years ago at FACEP talking about PTSD. And when somebody comes into the emergency room, how do you help them, when they come in crisis? And I've deployed twice, and I came home and thought, I'm just perfectly fine. And as I was researching that lecture, there was an awful lot of that sounded really uncomfortably personal when I was looking at the symptoms and the things that patients struggle with. And so reached out to my local VA, and I see a counselor through our vet center. But it took me 5 years to understand that the fact that I don't like big crowds, and if I go to a restaurant, I will sit with my back to a wall and I know where the exit is, that's actually not normal. But that's how you survived. And so I think that's one of the, I get off on these I go down the rabbit hole on a regular basis. I apologize. One of the very difficult things is realizing, because PTSD is not so much that it's a disease, it's that it's a reaction out of its proper place. And so the things that you do, sitting with your back to the wall and knowing where your exit is incredibly protective in Bagram. It is a life skill that you have to have. But you take that out of a war zone and bring it back here, and it's maladaptive. And so a lot of patients that have PTSD don't understand, or have a hard time understanding, because I say, how do you not know how to get out of this room? You might need that information. It doesn't feel abnormal because that's a survival skill. So very long roundabout answer to, we are understanding that it's not just patients and it's not just soldiers that have these struggles, and encouraging people to access those resources that are there is very important. And that's true in medicine as well, because if you heard my talk this morning, emergency physicians have rates of PTSD about like what our soldiers do. We are not immune as caregivers because of the experiences that we have with our patients. Great question.
Let's thank Dr. McGowan.
Thank you.
Thank you so much.